Andy, do you hear me?
Yeah, can you hear me?
I do, yes. How are you?
I'm good. How are you?
I'm very good. I haven't added anybody else yet, so I wanted to test that you could actually do a screen share first.
Yep, I think I can, but I can't actually find my.
Let me see. I'm gonna make you a. Oh wait, make you a co-host. I might give you more privileges.
Okay.
Oh, yeah. I see your screen.
Okay.
That's perfect. Is there a way of adjusting? It's like a little cutoff. Is that weird?
So let me. I know what I've done. Maybe hold on. Oh God.
It's not the end of the world, but.
No. Let me.
I think I lost you there. Are you still there? Okay. Yeah, that works great.
Brilliant. Okay.
Okay, I'm going to start. I was going to do one more thing. I was going to see if I could also stream it into the Facebook group that we have so that anybody that couldn't join in. It's a closed group. It should work.
But I'll let you do that.
Yeah, I'm just trying to make that active then.
So will we be able to take questions on this?
Yeah, there should be a chat feature on the bottom there. And
I can't see one yet, but fine. If I do that.
Okay. That should be starting. I'm going to start admitting people in a second. I think we'll just wait so people can join and then.
Yeah, sure.
Hi, everyone. It's almost 11 o'clock. We're going to wait till some other people join us, and then we'll start the webinar with Dr. Andrew January from Newcastle. There should be a chat feature if anybody wants to test it now. So we know we can take questions at the end. Sarah Cherry, I see you are logged on from Australia. I have no idea what time it is there, but thank you for joining us.
Ooh, it's going to be horribly early.
Yeah, I think so.
Like, I don't know, 4 o'clock in the morning or something.
Sarah, can you hear us? You won't be able to talk, I guess, unless I don't think anybody else could use the microphone, but Sarah, if you see a chat option, see if you, oh, I see a camera. I'm gonna try doing the chat option.
Do I need,
You could turn on the camera. I see you now too. You don't have to have a camera on. I mean,
okay.
Again, before, if I start my camera as well, let's see. Ah, there we go. So now people can see us as well and see the screen, I think.
Yeah.
I'm trying to see if the chat option works. And I see we have some people joining on Facebook as well. I see Nick Tesh is there. It says it's 1 a.m. where he is in Australia. And see Larissa is on from Italy. Cinderella. Question is, oh yes, people, I see Cindy, you chatted us. Good, that'll be a good place to put questions at the end. And did you see the chat? Are you able to see questions when it comes up?
I'm not sure, but I'm concentrating on the
present.
slide at the moment.
Yeah.
So
okay, that's fine.
We'll sort out the questions later.
Yeah. Okay. We have 1, 2, 3, 4, 5, 6, 7 people on so far. I think we'll wait maybe 2 more minutes and then we can get started.
Yeah, okay.
I think I'm supposed to be admitting more people. 1 second. Here we go. Laura. Hi, Laura. She signed on from Germany. We got a really great international group here.
Okay.
I have to keep an eye on the option to admit. I thought I said it that everyone gets admitted automatically, but I guess I did not. Maybe now they'll be able to join right away. Okay, I think we could get started and people will be joining us as so thank you everyone for joining us. This is a additional lecture as a continuation from the ones that Dr. Andrew Jennery gave at the IDF conference in June. This is one of the sessions we didn't have time for. It's called Are We Really Cured? Long-Term Outcomes Post-Transplant. And I will let Dr. Jennery get started. Thank you.
Thank you very much, Akiva. Can you hear me?
I hear you, and I'm assuming everyone else hears us.
Okay.
If there's any issues.
As long as somebody can hear me, that's fine.
Yes.
So thank you for helping set this up, and sorry that the technology eluded me for most of it anyway. So when I was at the IDF meeting, I was asked to give 2 lectures, and the first lecture we spent so much time answering questions that we didn't have time to give this one, and so agreed that we would try it on a webinar. It's the same lecture, I haven't changed it, and hopefully there'll be opportunities at the end of it for questions, and if not directly, then I guess we can do it by email and Skype and text and what have you. So there will certainly be some two-way communication. So the title of the lecture is, Are we really cured long-term outcomes post-transplant? And I think the answer is, I don't know. And I'll explain why I don't know, although I think I know some. Oh, right. Okay, so it doesn't. Oh, right. I'm going to have to do this one by one. So, conflict of interest. I have received travel grants from MEDAC. They make treosulfan, and we use treosulfan in transplanting our patients. So, what we're after really is a very long-term outcome after transplant. And one of the problems is that when you read manuscripts that talk about transplant, they'll often talk about 2 years or 3 years or 5 years post-transplant. And of course, either as parents or as patients, we're surely interested in 2, 3, 4, 5 years, but we really want to know 10, 20, 30, 40 years. And this is the longest term outcome that I am aware of. This is actually a patient with severe combined immune deficiency, X-linked SCID, who was transplanted in the Netherlands. In 1968, there were 3 transplants performed, really the first ever successful transplants, and they were all in small children with primary immunodeficiency. This was the first patient in Europe. He had a transplant from his sister. He didn't have any chemotherapy. He does have a problem with warts, which are related to the SCID and nothing to do with the transplant. And he doesn't have great T-cell output from his thymus, partly because it was an unconditioned transplant. But this patient is alive and fairly well and was transplanted in 1968. So I guess, what do you mean by long term? As I say, most studies look at 2 to 5 years. The first transplants were in 1968. So I can only give you at most 51 years follow-up data. And is that long enough? I guess for some of us that isn't, actually. And we'd like to know beyond the 51 years. And all I can say to that is, well, we are on a journey and we're still finding out about that. I'm going to keep pressing the wrong button here, so just bear with me. So this was a manuscript taken, or sorry, a statement taken from a manuscript written by Rob Wynne in Manchester and Jaap-Jan Bolens, who at the time was in Utrecht but is now in New York. And in their article, they were talking about transplant for non-malignant disease, such as CD40 ligand deficiency. And they have this statement in there, which is that transplant might be the most secure way to be alive in 3 decades, but it's also the most likely way of being dead in 3 months. And that's a fairly stark statement, and I think we need to be careful as we think about what it means. But what it does mean is that the transplant process itself might have some risks associated with it. On the other hand, when we're talking about transplanting patients with non-malignant disease, they've usually got a problem, and therefore not doing a transplant might also have risks associated with it. And so I think for each patient, we need to consider the most appropriate treatment pathway. And we also need to remember the outcomes not only with transplant, but also the outcomes if we don't do a transplant. And so there is a balance, but I'm not sure that balance is always as straightforward as we think it is. And this was some data, I think, that I showed in Washington back in June. This is taken from Miti de Marina's paper published 3 years ago. And this was her big analysis of 176 patients with hyper-IgM syndrome. And if you look at the curve, then there is a mortality associated with it. And this is up to 30, not quite 40 years. So I think we can say that if you've got hyper-IgM syndrome, it is not a benign disease. Just having the disease is associated with a mortality. So what are the risks of transplant? Well, I think we can split them broadly into 3 areas. The first is related to the stem cells themselves, and that's graft failure. So the transplant just doesn't work. The second is issues related to doing the transplant, so transplant-associated morbidity, which sometimes might lead to mortality. And the particular things that are important here are graft versus host disease something called veno-occlusive disease, which is a complication of vessels post-transplant, particularly infection. And then one of the things that people worry about is the risk of secondary cancers. I think that is a particular risk in patients who are being transplanted for leukemia. I think it's much less of a risk for patients who have a non-malignant disease and have a transplant for that. And I will show you some data about that at the end of the talk. But then there are also risks which are disease related, and they're due to pre-existing end organ damage. So what do I mean by that? Well, if you've already got lung damage and bronchiectasis, and you have a transplant and it's successful, your lungs aren't going to get better. They may not deteriorate further, but you are going to be left either with lung damage, or if you had pre-existing liver damage, potentially with some liver damage as well. And so that might cause problems going forward, which aren't directly related to the transplant, but are related to having had hyper IgM syndrome. And so that's another thing to think about when we're considering transplant. And so from Matey's paper published 3 years ago, she had a table with the cause of death of patients with hyper IgM syndrome, and I showed that at the meeting in Washington, and a lot of the deaths were actually due to malignancies of the liver or due to cryptosporidium. And this table shows the causes of death in patients who had had a transplant. And I would say that these are largely causes of death that we would recognize as being a complication of transplant. So adenovirus is a virus, and it can cause a problem through transplant. So 2 patients died of adenovirus infection. Perhaps slightly more unusually, 1 patient died of pneumocystis carinii pneumonia, or its new name is pneumocystis jirovecii. I say that's unusual because we can treat that. So it's an unlucky way to die through transplant, but it's possible. Cryptosporidium, obviously, we worry about. And you can see here cryptosporidium, liver failure with cryptosporidium. And here cryptosporidium is likely to be implicated as well. Graft versus host disease and veno-occlusive disease, which are not specific to hyper IgM, but are specific problems that we see through transplant. And then progressive disease with a neurological deterioration, which I think is likely to be an occult or a hidden, probably viral infection in the brain as a result of having hyper IgM syndrome. And then that got worse during transplant. Now, what I'm going to show you is some graphs, and here, in fact, is our in Newcastle hyper IgM series. I did show some of this data when we were in Washington. This is our 5-year, in fact, it goes up to 15 years, but we've measured a 5-year overall survival in patients transplanted since 2000. There are 12 of those, and you can see in that group of patients, it's 100% survival. In the patients transplanted beforehand, the survival is really quite poor. I think the main reason for that is that these were generally older patients who had a lot of pre-existing liver or lung disease before transplant and didn't tolerate the transplant well. I think if we were transplanting these patients today, we would probably have a better overall figure, because I think our transplant techniques are better than they were then. But even so, this is going to be an at-risk group, patients who've already got infection or lung damage or liver damage. So there is actually very little information about the long-term outcome of transplant for hyper IgM syndrome, but we do have quite a lot of data on long-term outcomes of transplant for other immunodeficiencies. And these are data that we published a long time ago now, almost 10 years ago, from the big immunodeficiency database in Paris, the European database. And this is looking at patients with severe combined no, it's not, sorry. This is looking at patients with other immunodeficiencies, so not SCID, but other immunodeficiencies. And I think there are 2 really good take-home messages. One is that over time things have got better. It looks like in this series that the more recent series wasn't much better than the one preceding, but you can see that over time our survival has got better. And then there are some data showing that depending on your donor, outcome is better as well. Now, one of the things I think I said when I was in Washington is that we have to be very careful with these data because we're always looking at data that's already well out of date. And I would say today that the outcome of transplant is probably fairly similar whether we use an unrelated donor, a matched sibling, or even a T-cell depleted half-matched donor. So this was true when it was published. I don't think it's quite so true now. This is some survival data of patients with chronic granulomatous disease, again from our centre. We've done 55 patients since 1998. And again, you can see here that age at transplant has quite an important effect. And it's not that less than 5 years is magic and more than 5 years is a problem, but of course, the older you are, the more likely you are to have encountered infection and maybe actually sustained liver damage and lung damage, to have cryptosporidium, to have bronchiectasis. And that's what makes the difference in the older patients. It's not the age per se, it's the fact that if you're older, you're more likely to have had some problems. Oh, I see what I've done. So this was, actually this is our CGD patients again. And this is, no, it's not, sorry, this is our CD40 ligand patients. I'd left this slide out originally and I put it in this morning. I've actually put it in the wrong place. So this is our CD40 ligand patients, and you can see here, again, age less than 5 years and age more than 5 years, and that we have a much better survival in the younger group than in the older group. The same as for CGD, and it's for similar reasons. It's that actually patients who are younger are less likely to have had organ damage and tolerate the transplant better. This is another disease. This is called IPEX syndrome. It's another immunodeficiency which can involve infection and inflammation. And what we see here is a percentage survival, transplant versus a different treatment of immunosuppression. I think I would be careful how I interpret these results, because I think that our transplant survival results are better. But actually what is important is disease-free survival, not only overall survival, but disease-free survival. And what you see here is that patients who've had a transplant go on essentially to have no symptoms, whereas those having alternative treatments, immunosuppression in this case, as they get older, they still have disease going on, and it's not controlled by the treatments that they're taking. So I think one of the advantages of transplantation is that it will cure the disease, and it will mean that you don't need to be on any further treatments. You no longer have to worry about the infections, about boiling water, about developing tumours, because actually the transplant abolishes those risks. These are data which are not yet published. This is a study that I'm still involved with, looking at the very long-term outcome of patients with severe combined immunodeficiency. And this is, you can see here, up to 45, or in fact now, it was a few years ago we were collecting the data, it'll now be 50 years. And you can see the overall survival of this cohort, and the overall survival if they had chemotherapy or if they didn't have chemotherapy. That's not relevant for CD40 ligand deficiency, but I think the important message is look at this curve. So there is a risk of dying early in transplant, but if you survive the transplant, the curve is actually pretty straight. In other words, if you get over the initial problems, then you're likely to be cured and you're not likely to have problems going forward in the long term. These are data taken from our manuscript that we published earlier this year. This was 130 patients with CD40 ligand deficiency who'd had a transplant. It's data from all around the world. And again, it shows things that I've already been saying, but this is specifically for CD40 ligand deficiency. So you can see that transplanting in the later area, since 2000, you get a better survival than before then. And actually, again, the younger age group does better than the older age group, and that's true even when we look at the different eras. And again, if we look at damage before transplant versus no damage, patients who've got no damage do much better than patients who've got damage. And again, that reflects with age. So the older you are, the more likely you are to have had a organ damage, and the less likely you are to do well during transplant. These are complicated graphs, and this is for something called event-free survival. So this isn't whether you're alive or dead, but it's mainly alive, but did you have any problems after the transplant? And the events that we specifically looked at were graft failure or failure of engraftment, needing a second transplant, needing a boost or a donor lymphocyte infusion, developing very bad graft versus host disease or chronic graft versus host disease, or needing immunoglobulin treatment for more than 2 years after transplant. And we also put death into that as well. And you can see, again, looking at these as events, there are particular associations with the year that you're transplanted. So again, in the modern era, we have much fewer significant events than we did previously. But there is an impact because of the conditioning regimen as well. And I think one of the key messages that came out of this paper was that really we need myeloablative conditioning. Here in Newcastle, we prefer the low toxicity myeloablative conditioning regimen using treosulfan. You can also use busulfan, targeting the dose so that you try and avoid the toxicities. But you really do need a myeloablative conditioning regimen to get a good graft in and end up not needing some of the, not developing some of these problems. These graphs are looking at the degree of donor chimerism after the transplant. So after first transplant, and if patients needed a second transplant or more, the amount of chimerism that patients have after that second procedure. Black is complete donor chimerism, dark grey is partial donor chimerism, and light grey is absent. So this is going to be failed transplant. And you can see actually that things are fairly steady. At 6 months, if you've got good donor chimerism, then pretty much that stays till 12 months and till last follow-up, which is more than 1 year in this graph, and for many patients is going to be 5, 10, even 15 years post-transplant. And that's also true if you need a second or a third transplant as well. So I think if we get chimerism and we get engraftment, then the data suggests that that is likely to persist in the long term. And then this is looking at the donor chimerism, but looking at different cell types. So this is looking at the T cells, this is looking at the neutrophil cells, and then this is looking at the B cells. And what we can see is that you may get different sorts of chimerism, but a good number of patients have either complete or partial donor chimerism. Over 80% or nearly 80% of patients have good donor T cell chimerism. B cell chimerism is perhaps a bit more mixed, but actually it doesn't matter, because in CD40 ligand deficiency, the B cells work. So if you end up with donor T cells and your own B cells, you should still be able to make antibody and be able to come off immunoglobulin replacement. One of the things that we were able to show, because you may kind of get the feeling, or have got the feeling through listening to people talk and reading articles, that CD40 ligand deficiency can be quite tricky to transplant. I think that's true, although these results I think are very good. But what we were able to show is that there are more likely to be problems with chimerism in patients that develop a viral infection immediately after the transplant compared to those that don't. And I think the reason for that is that even if you've got CD40 ligand deficiency, your T cells are pretty good at fighting virus. And when you've had your conditioning, usually we don't manage to get rid of all of the recipient T cells. And so if you get an infection, then if you've got any of your own T cells left, they will expand and multiply to try and fight that infection in the first few weeks post-transplant. And they kind of crowd the space out for the donor cells. So you're probably going to be better off if you don't get a viral infection during transplant than if you do. But even if you do, there's still a good chance that you will have enough donor chimerism to be at least partially cured, if not completely cured. And then these are data that Métis published in her big paper looking at quality of life. And one of the questions I've had to me is, are we living or are we just breathing? In other words, after a transplant, have you got a good quality of life, or are you just existing and getting by day to day? Now, we don't really have good quality data for that. And so we have to extrapolate. These are data that Métis de la Marina took from the hyper-IgM paper that she put together. And we can see at this end of the graph is a good quality of life, and at this end of the graph is a poor quality of life. And at the top, we've got patients who had a transplant, and at the bottom is patients who didn't have a transplant. So I think we can probably say that the quality of life score that was used here suggests that patients who've been transplanted overall are better off in terms of life quality than those that haven't. But what we can do is extrapolate data from other diseases, and this again is a chronic granulomatous disease cohort. It's the UK cohort of children, and we were able to look at patients who'd been transplanted and compare them with patients who hadn't been transplanted. And we did a proper validated quality of life score. We asked the parents and we asked the patients if they were old enough. We didn't ask them any questions until they were at least a year post-transplant, because we wanted to make sure they'd got over that procedure. But you can see when we compare no transplant versus normal controls, there's a significant difference. So anything less than 0.05 is felt to be important, and you can see that many of these numbers are much smaller than that. And what that means is that the non-transplant patients had a much worse quality of life than the normal controls when we asked the parents, but actually when we asked the patients as well. When we looked at the patients with CGD who'd been transplanted, we found that those numbers changed quite dramatically compared to the normal controls. And these are now no longer 0.05, they're much bigger than that. And that means there is no difference between post-transplant patients and the UK norms. And then finally, when we compared the post-transplant patients with the pre-transplant patients, again, you can see that there's a significant difference. Perhaps unsurprisingly, but the post-transplant patients have a normal quality of life, and it's much better than those who haven't had a transplant. Now, these carefully measured quality of life data are not available for CD40 ligand deficiency. These are a fairly crude score, and this is the best we've got, but it does suggest that if we did a similar survey, we would probably find similar results. So one of the concerns that people have is, are they likely to develop a cancer after the transplant? And I think it's difficult to be certain in trying to answer that question. We did a joint survey with Great Ormond Street looking at all of the patients with immune deficiency that we've transplanted and comparing the two groups. And we were looking to see if any of those patients had developed a cancer after the transplant. Now, of course, just because you've had an immune deficiency and had a transplant doesn't mean that you might not have developed cancer anyway. But we were looking to see whether there are any features that were worrying. And we didn't find many cancers anyway. We only found 12 patients that had developed a cancer. This is out of probably over 600 patients that have been transplanted. And some of these are actually due to the disease itself, which hasn't been completely cured by the transplant process. So we've not got rid of all of the cells, and therefore the diseased cells themselves are able to develop a cancer. This patient, I think the cancer was due to some of the treatment that they were on before they were transplanted, the antifungal treatment. There was only one patient with CD40 ligand in this series, and they developed a renal or a kidney cell cancer. And I'm struggling to work out specifically why that might be. I can't think of an association with CD40 ligand deficiency, and I can't find an association specifically with having a transplant. So it may be that they were just unlucky and that was going to happen anyway. So in conclusion, are we really cured after transplant for CD40 ligand deficiency? I would say from the data that we've got, and the data aren't perfect, but as far as we can tell, the answer is yes. And I do think that transplanting immune deficiency is different to transplanting, for instance, leukemia, and there are lessons we can learn from one disease that we can extrapolate to another. And so I think if you've got good donor stem cells in the bone marrow, then you are likely to remain with good donor stem cells for the rest of your life. They are likely to produce good T cells, which are going to protect against infection. And we know that in CD40 ligand deficiency, the big risk of cancer, particularly in the liver, is due to faulty T cells allowing infection there. And when you've got good T cells, we would imagine that you will be protected from that going forward. But I think long-term data are necessary. We do need longer-term follow-up on our patients. And I think particularly for younger patients, transplant may be better than not transplant. Many of those patients are off immunoglobulin and off other prophylaxis. I suspect that they've got a better quality of life. But you do have to weigh that against the risk of transplant-related morbidity and mortality. I think if you are young and fairly well, that is a small risk, but it's not a zero risk. And I think if you're older, if you're particularly into adult age, then the risk of transplant probably is higher, and that therefore is quite a different balance that you need to be thinking about. But I would argue that it's always good to talk to a specialist centre early so that you can get the most up-to-date advice about the way to treat CD40 ligand deficiency, what current transplant results are like, what the treatment options are, and actually whether, for instance, a donor is available. So quite a lot of people help put some of these data together. Mary and Andrew work in the unit. Francesca put together the big series that we published this year. Métis put the bigger series together that was published 2 or 3 years ago. Najib was looking at the cancer for us, and Suhan has looked at our own series. And Alexandra looked at the long-term SCID outcomes as well, and then the SCETID database where we've got a lot of information as well. So that's all I've got to say about that. I think there's probably a lot to think about there. And if people have got questions and we're able to take them, then I'm happy to at least try and answer them if I can. Thank you.
Thank you. Thank you so much, Dr. Henry. That was a really amazing presentation. We have around 14 people online, so I'm hoping that people will have questions. And you could, if you're watching it on Facebook, if you comment your question, I will read it out loud. If you're on the Zoom platform, there should be an option to put your question in the chat, and I can also read it out loud. I think I'll start off by saying, as far as quality of life survey go, I know that Mete in Seattle is planning another survey. We've been working with her and trying to make that happen. They just applied for a research grant as well, so I think that will come out in the next year, hopefully even sooner. I know that they're working on getting an IRB approval for a WAS quality of life survey at the same time, so I'm going to do it all together, and then it'll be an international survey. So I'm hoping that everyone from our group can participate in that, and then we'll hopefully have better data on quality of life for hyper-IgM patients transplanted and not transplanted.
Yeah, sure.
Before we get any other questions, I mean, from people in the group, I'm going to ask one question myself. When we look at malignancies, something I've heard recently is possibly with mixed chimerism, which we saw, around 30 or 40% of the hyper-IgM patients might have had, mixed chimerism, even high mixed chimerism. The donor cells that are left, the 20% or so, sorry, not the host cells that are left, 20% or so, that have been through chemotherapy. What do we feel about the risk then that could lead to malignancy? Because I think I'm hearing some rumors now that possibly something needs to be watched carefully.
Yeah, I'm not sure I would buy that, actually. I mean, I don't have a problem with watching it fairly carefully, but I think, as I say, I think the main cancer risk in CD40 ligand deficiency is the risk to the biliary tree and to the liver. And the driver for that risk is cryptosporidial infection. And if you have got cells that are able to stop that, then I think that risk, at very least, is going to diminish and hopefully be abolished. And we know, for instance, even if you've got mixed T-cell chimerism, our patients who are no longer taking prophylaxis, no longer using boiled water, don't present with cryptosporidial infection. You probably only need about 10 or 15% of T cells that are working effectively to try and prevent that infection. So I think even in a mixed chimerism situation, I would be reasonably reassured, as well as I think we can be, that your cancer risk is low, and it's certainly going to be lower than if you hadn't had a transplant.
It's actually a great point with the risk, long-term risk of getting crypto, and whether you have a certain amount of T cells that are working. So we have a group of patients in our cohort that are several years or even many years post-transplant that might have around 7, 10, 15% donor left, and they're not going towards another transplant. So is there a way of really finding out whether, I mean, so they're still on IVIG, whether they'll be protected from the crypto?
Yeah, I mean, I think, so the IVIG is separate. You know, we tend to think of hyper IgM syndrome as being an antibody problem because patients are on immunoglobulin treatment, but actually the really big problem is the T cells activating, for instance, things like macrophages. So, and that means that this is a T cell problem predominantly, not a B cell problem, even though we're giving antibody. And it's that bit of the hyper IgM syndrome that the transplant tries to address by changing the T cells. And again, I think we don't know for certain how low you can go. I think at 10, 15%, I would be reasonably happy that those patients are going to be protected. And if you like, the proof of the pudding is if they're not taking prophylaxis and they're not getting cryptosporidium, they've got enough immunity to keep them safe.
Right, no, that's a great. So Cinderella from Louisiana was asking specifically about that. So her son is still on IVIG because his B cells were knocked out during the transplant. But you would consider that, I mean, essentially cured of the hyper IgM because he has enough of the functioning T cells. And
I think that's right. I think we've got one or two, no, I think only one patient on immunoglobulin treatment, but they've got good T cell function. And so in an ideal world, you would need no treatment at all. But if all you're needing is antibody replacement, and there are various reasons why that might happen. There are some complications through transplant where we might need to give treatment, which means your B cells don't subsequently work. That's unfortunate if it's you that's happening to, but that's not the major issue in CD40 ligand deficiency. The major issue is T cell dysfunction, and as long as you've got some donor T cells, as I say, probably around about 10%, I think you're going to be protected as far as we know today.
Okay, thank you. Any other questions? Either people watching on Facebook, I see we have 10 people on Facebook watching live. You could comment your questions. Not, we might end a little earlier. Let's see if there's anybody else. I think so. The group is quiet. we had a much livelier group when people were in
almost
person.
asleep, to be fair, because it's very late at night for them.
Yes. Okay. Well, this was really great. I'm very glad that, I mean, the fact that this platform worked well, I think, gives me hope that maybe we could do this with some of our other scientific advisors and get some more information. Oh, wait, we have someone just saying hello. Robin Feynman from New Jersey is saying hello and thank you, Dr. Gentry. Nick Tesh, actually from Australia, is saying, wait, let me just read this. Quality of life study is vital data. It's great to see it gets attention. And he's saying thank you. His question is, are there any treatments available for T cells post-transplant now or in development? Nick, I don't entirely understand the question.
So at the moment, the only curative treatment for CD40 ligand deficiency is transplant. There are other treatments which are being developed, and in particular gene therapy, probably to change T cells in the blood rather than stem cells in the bone marrow. But I think that as a treatment is going to be some way off yet, probably at least 5 years, maybe even longer than that. So at the moment, if you're looking for a curative treatment, the only treatment available is some form of bone marrow transplant. But
So
other things may be available in the future.
The one that's been worked on, you mentioned, so it would be gene therapy, not gene editing, so gene therapy, and there would be a T cell. So essentially it would be the same product for all patients, that they would be able to get some sort of gene-corrected T cells.
I mean, well, so gene editing is just a form of gene therapy. Then there are different ways of doing gene therapy. I think probably the one that's going to be effective in CD40 ligand is likely to be a gene editing process. But I think what people may do is edit the T cell rather than edit the stem cell. But actually in CD40 ligand deficiency, that might be enough.
Right. So that's similar to the study that, the proof of concept that Dr. Torgerson's group in Seattle did a few years ago.
Exactly right. Exactly right.
Right. Okay. Nick, did that answer your question? I'm hoping so. Do we have any other questions? Oh, we do have one. Laura Wilms from Germany is asking, so they have a 2-year-old now. Would you recommend waiting for gene therapy?
No, I wouldn't. Because if you look at the history of gene therapy, it's one of stop, start, stop, start. And ADA gene therapy for ADA SCID, which is one of the first that has been going, is actually extremely successful now, but it's taken about 30 years to get there. And I think at the moment we can say with some confidence that bone marrow transplant is, I would say, reasonably safe and successful. And I think if you're looking for a cure, I would just go for what we've got at the moment. The problem with gene therapy for CD40 ligand is that by the time it's available, and it's available widely rather than just in 1 or 2 centers in the world, it may be too late for you. So I think if you're thinking about a curative approach now, I would go for bone marrow transplant. I wouldn't risk waiting, because I don't know how long you're going to have to wait.
That's great. She says, perfect, thanks.
Okay.
Okay. I think everyone knows this already, but I will mention that today is my son Idon's 3-year transplant anniversary, and he's off in camp someplace in northern New York without a worry in the world. So.
And you're not worrying about him catching cryptosporidium?
Oh my God! I mean, there's been issues with the pool closing down for fecal matter and so on. So I'm not worried at all about him catching anything. I mean, I witnessed how dirty it is there. We do have a question. Michelle from Florida. Maybe it was answered already. So she's asking again, what is a normal level for transplant for CD40 ligand level after transplant, and what would a rejection look like?
Well, so after transplant, we do measure the CD40 ligand level, but the level itself isn't very helpful, because even in normal people, it goes up and down. What we actually look at is the amount of donor, and we call that donor chimerism. So we look for the donor DNA in the blood cells. I think you could argue there isn't a normal level, because in nature, we shouldn't be putting bone marrow in different people. From our perspective, a completely successful transplant would be 100% donor and no host or no recipient. But it doesn't always work like that. And in CD40 ligand deficiency, we often find what we call mixed chimerism, where we find some donor and some host. I would be okay with it going down to about 10-15% donor. I think after that, I might be thinking about maybe another procedure.
And Heather is asking, Heather says, I was wondering if in the studies that show a shortened lifespan for hyper-IgM without transplant, are they on regular IVIG and prophylactic background?
Yeah, so one of the problem with all of these studies, of course, is that if you've got people in your curve that are 40 years old, first of all, they may have been quite old when they were diagnosed, so they weren't getting the proper treatment before diagnosis. And even if they were diagnosed when they were fairly young, we didn't actually understand what sort of things that we should be doing. So we didn't know about prophylaxis for cryptosporidium, boiling water. We maybe didn't know about Cetrin. So I think that some of those, if you like, early deaths are because we didn't understand about the disease and patients weren't being offered the appropriate treatments, which is going to be largely different today. But you are still dependent today on seeing the right doctors. And if your doctor doesn't understand about CD40 ligand deficiency, then you may not be getting the appropriate prophylactic treatment anyway. So I think, the question is fair. You know, the older patients may not have been treated optimally 20, 30, 40 years ago. But even today, we know of patients that, and I'm sure within your group, there are similar stories of patients that parents know there's a problem, but they struggle to get doctors to listen to them, and they struggle to get a diagnosis.
Right. Robin is asking, do we know how far out from transplant is the furthest patient? For example, is anybody being tracked 10 years or more?
Oh gosh, yeah. I mean, we did our first one. Just trying to think. Well, our first one is probably early 2000. So we've certainly got, I think, at least 15 years follow-up. So there's definitely more than 5 years follow-up. We're certainly probably not looking at 40 years follow-up.
And Cindy is adding that she's 12 years. They're 12 years post-transplant.
Okay.
And I
they're
think
going to be in the older group, I think.
Yeah, they're in their other group. And I believe Sarah and Nick's cousin is around 15, 16 years post-transplant in Australia.
Okay.
Do we have any other questions, or should we, I don't want to end it early while people are still maybe writing a question. Oh, everyone's asking, are those patients doing well?
Yes.
So yes.
So all of our survivors are doing very well. As I say, I think one of them is on immunoglobulin still, but they're living, I don't know how you define a normal life, but they're doing normal things.
Yeah. Oh, so Sarah's saying that her cousin is 19 years post-transplant. He might be one of the first transplants that are still alive.
Yeah, I mean, I think there may be some a wee bit more than that, but I mean, he's certainly going to be in the first cohort of patients that were transplanted. I think my question to her would be, is he well?
Sarah, you heard that? I don't know. You don't have to share it. There's information, but we still need to get him in the group. I know we've been asking, but I think I think he's over it.
Okay.
He's married, 2 kids, and doing very well. So that's great.
That's quite normal.
Yeah. I'll give you guys another 20, 30 seconds to ask any more questions, and then we could call it a day and thank Dr. January. I'm looking, oh, we got another question. No, not a question. It's just Nick chiming in on his cousin that he's doing very well.
Good.
There was a successful ceiling match he's adding. So that's great.
Okay.
Okay, well, thank you so much. This was really, really great. The session is recorded. I should be able to post. Oh, sorry, Lisa's asking another question. Sorry about that. You mentioned worrying about crypto I said I'm not worried about crypto while my son is in camp. So we've had a few issues where the pool had been closed for children who might have had an accident, and I mean, I don't worry about it at all. And he's drinking the water from everything, and he's really, carefree at this point. So we're very happy about that.
Yeah, I think from a parental perspective, it's one of the things that we don't think about so much. But if you're a parent looking after a child with CD40 ligand deficiency, I guess there's this chronic kind of worry and concern at the back of your mind. And actually, with a successful transplant, you can forget about all that.
That's great to hear. And it's not easy to forget. I think we all, still worry, but it's amazing how far I've come. I'll just share that. I mean, we had a parent night at the camp, and he down at the end of the camp, his water bottle that he drinks from, the part that's touching his mouth, is literally upside down on the floor of the bus. And he just picks it up and drinks it again. And I was like, this would never have been something that I would have let him do
Exactly.
3 years ago. So we've come a long way. Okay, well, thank you very much, Dr. January. This is really great. The recording will be online for the rest of the group to watch. If anybody has any questions, you could comment them. I'll try passing them along.
Yeah,
Maybe
sure.
we'll do this again sometime. Yes. Okay, I'm going to end that now. Thank you very much, everyone, for joining.
Perfect. Have a good weekend.
Take care. Bye-bye.
Thanks.